So I think we're going to get started because this is a talk that we're going to be giving in a 75-minute slot next week at the FAAPMR, and so I'm not sure we're going to speed talk through it and hope to get you out of here in a timely fashion. But we want to just go ahead. So for those of you that don't know me, I'm Heather Baer. I'm one of the faculty here in the rehab department, and I'm also movement disorders trained through this university from the Department of Neurology. I've been working with people who are affected by Parkinson's disease for quite a long time, and I'm working in a very big team at the university. We were just awarded the designation as a Parkinson's Foundation Center of Excellence recently, which is a great thing. And it really speaks to just how much depth there is at the university in terms of what we have in services for individuals with Parkinson's disease. And today I have with me two of those colleagues, which is wonderful. I have Christina Vaughan over here. She's a movement disorders trained neurologist who has just recently taken over the palliative care program as, I don't know if you know Dr. Benzie Kluger, but he's moving on. And Dr. Jane Ott, who's a neuro-PT who I've been working with for nearly decades and has at least over a decade of experience with Parkinson's disease. What I hope to do is give you the sense that Parkinson's disease really should be considered a core rehab diagnosis, and it's only by some quirk of history and tradition that it's not. Over the past couple of decades, there's been a huge shift in how we conceptualize or understand Parkinson's disease, whereas we thought at first that it was really a movement disorder, a motor systems disease. And generally, people involved in the care were a neurologist and maybe a physical therapist. The thought was that there were very, say, disease that's progressive with an inexorable arc towards decline, and there was very little that we could do about it. But it's actually a multi-system disorder. And in fact, the non-motor symptoms of Parkinson's disease are sometimes more distressful and problematic to these individuals than the motor symptoms. For some of my patients, anxiety is the worst thing. And for some, it's the dysautonomia with orthostatic hypotension or their pain. There's a lot of pain. And as a multi-system disorder and the one that exists and somebody lives with for many, many years, it really requires, team approach. And this is, I'm sure I'm not getting everybody who should be involved in this team. But if you really think about what comprehensive management should look like as we go along in time, and I think we're on the cusp of it, we will have neuroprotective interventions. We do think that exercise is a neuroprotective intervention, but others. And activity-based treatments have turned out to be extremely important in the management of Parkinson's disease. Of course, we have pharmacologic approaches, and some of them are quite powerful, but we need rehabilitation interventions all along the course, and surgery at some point will become helpful for some individuals, as well as palliative care, which we'll talk about in some depth. So these are where we're focusing today. What I really want people to understand is that with some disease-specific knowledge, some investment in learning something about Parkinson's disease, together with the skills that we all have or we're developing, that really all of us could be involved in some aspect of Parkinson's disease rehabilitation. So I want you to think about it just like we think about strokes. So somebody has a stroke, they may be seen by a neurologist or a neurosurgeon or both, and there's a period of stabilization and consideration of secondary prophylaxis. And at that point, a team gets involved in the care going forward, right? And we, as physiatrists, are involved in managing gait disorders, hypertonia, bowel issues, bladder issues, dysphagia. Oops, what happened there? Sorry, this cool little thing on my hand has buttons that are really close together. But think that it's really the same, or it should be the same with Parkinson's. So somebody develops Parkinsonism, we rule out some other disorders that could cause it. They're given a provisional diagnosis by a movement disorders expert of Parkinson's disease, and then a multidisciplinary group should be taking care of them. And as physiatrists, we can manage pain, gait disorders, bladder problems, bowel, dysphagia and drooling, dystonia, depression and anxiety, and a lot of other things. So very similar. The goals of treatment are to improve or maintain physical capacity, prevent inactivity or activity intolerance, prevent or delay secondary sequelae like falls with injuries, provide tools for self-management, provide adaptive equipment, educate patients, families, and caregivers, which we do at every single visit, decrease social isolation, which is huge, and we think slow the progression of Parkinson's disease. So this is an example of someone early on in their course. This 63-year-old right-handed man has noticed, kind of in retrospect, that over the past couple of years, he's had difficulty with his dexterity, using a keyboard, brushing his teeth, buttoning his shirt. But when he really started to understand something was wrong was when the tremor came up. So he's had tremor for about 3 months in his hand. It's at rest. His wife notices he's been lagging behind her on hikes. Turns out when he asked that he had adhesive capsulitis a couple of years ago and has some residual restrictions and range of motion and pain. And he's anxious and has decreased activity tolerance and fatigues easily. So on exam, he has a head-forward posture, which most of us do, decreased range of motion at the right shoulder and impingement signs, some mild slowness of his movement on the right side, and some rigidity, and a little bit of a rest tremor, and reduced arm swing when he walks, and a little bit of a foot drag. Sometimes patients look like they've had a stroke. So he goes through an evaluation. There's no red flags. He can think that it's something else, and he's diagnosed with probable Parkinson's disease. And he may have some medications initiated at the start or may not. If they are, often the targets are to improve movement fluidity and automaticity and amplitude, and sometimes they help the tremor. So what can we do? Well, we know that deconditioning actually happens before the diagnosis of Parkinson's. By the time people are diagnosed, they've just kind of subtly stopped doing, done less and less. And so we're kind of behind just at the start. And there are a lot of activity-based treatments that are available, and people tend to gravitate towards things they like. And there's a lot of those. Sometimes, they need specific things. And Dr. Ott will talk about it. Anxiety is very common, as I said, about 40% of patients. It could be generalized anxiety, social anxiety, panic attacks. It's not as well studied as depression, so there are no randomized controlled trials in Parkinson's and anxiety, but it is comorbid with depression, and so if you look at those studies and they talk about anxiety, there's some benefit from things that work for the depression, and those are kind of behavioral therapy and relaxation strategies. Pramipexole, which is a dopamine agonist, can be helpful for depression and anxiety, as well as venlafaxine, paroxetine, and nortriptyline, which sometimes is limited by side effects. And sometimes we use benzos. The shoulder pain, it turns out that it's not uncommon to undergo a shoulder surgery or have shoulder issues within a few years of the diagnosis of Parkinson's disease. In one study of 150 people, 8% had had adhesive capsulitis within the 2 years before their diagnosis. We think that it's more on the affected side. We think it's a mixture of bradykinesia, slowness of movement, and rigidity that alters the biomechanics in a joint that is already kind of, we're all at risk of shoulder issues. And so treatment is to try to improve that rigidity and slowness if possible with medications, and then just go at it like you would anybody's shoulder. And sleep issues, there's a ton of them in Parkinson's. So fragmented sleep can be because of REM behavioral disorder, which often predates the onset of the motor symptoms. That REM behavioral disorder can be accentuated or even provoked by SNRIs, SSRIs, and TCAs, and so you have to think about whether you're actually causing it. But if it's enough of a problem, melatonin can be effective in low doses, and if not that, clonazepam. There's a little bit of literature on Lunesta. Tremor, because some people have pretty substantial rest tremor. If you think about when they lay down, that can come out. So giving a dopaminergic, like long-acting one, like the reticotine patch, can help, or some other dopaminergic. We used to give anticholinergics, but we try not to now because of the literature on dementia. But the reason I'm talking about this is getting good restorative sleep has a tremendous effect on function in the day. Restless leg syndrome is comorbid with Parkinson's disease. The physiology is not well understood. Where people are usually on dopamine, they may be on dopaminergics, which can be very effective, but they cause augmentation, or they have a risk of augmentation, which creates more and more symptoms into the day. And so pregabalin or gabapentin can be helpful and is preferred. But poor sleep hygiene is common, and so education is what we do for that. Anxiety and depression we talked about. Nocturia, limiting fluids after dinner is a low-hanging fruit, but sometimes people need to have a full, workup to figure out why this is occurring. But that's very problematic, and often they just can't get back to sleep because of anxiety or whatever. So this is a more advanced patient, 83-year-old woman, whose real concerns are more her dysphagia and drooling, neurogenic orthostatic hypotension, painful foot dystonia, and postural instability with falls. Dysphagia and drooling are interconnected. So if somebody presents and says they're having drooling, you wonder, well, you're not swallowing automatically. It's not that you're producing more saliva, and maybe you're actually having some dysphagia, and we should work that up. So they may or may not actually even say they have it. So certainly an evaluation is important for just the dysphagia and the drooling. But when it comes to treating drooling, we generally go straight to botulinum toxin, and those are easy. Those injections are easy to do. Some people do them under ultrasound; others just do it anatomically. Xeomin and Myablock are FDA approved for this indication, and it can be quite effective. And it saves us from giving these anticholinergic drugs, but we do use those sometimes as well. And then neurogenic orthostatic hypotension is sometimes the most difficult thing that I treat. And often these people, because they have dysautonomia, have supine hypertension and standing hypotension, very labile pressures, and it limits their treatment for their medications, or it limits what you can do with their Parkinson's meds, because they all drop people's blood pressures. And it often leads to falls and confusion, and it's just a big issue. So, we always start with non-pharmacologic things like hydration, which is a problem because people have a lot of hyperactivity in their bladders and they don't want to drink because they don't want to pee, or they have dysphagia and they're not drinking as much because they're having trouble with thin liquids. They don't really know it, but they just start restricting their liquids. Elevating the head of the bed. Compression socks or stockings are a hard sell, but they can be helpful. Increasing salt in the diet, abdominal binders, minimizing alcohol and carbohydrates, and tilt table therapy if it's available, which we don't have. But we often have to go to pharmacologic treatments. If somebody seems to be fluid down, we may try fludrocortisone and then monitor their potassium. Otherwise, droxidopa, which is Northera, or midodrine are commonly used. There's some literature for atomexetine, which is Strattera. But it's not uncommon to have to support people's blood pressure during the day and lower it at night. And I have a cardiologist in the Boulder Clinic. I've turned into a Parkinson's cardiologist just to help me with this because it can be complicated, especially if there's some cardiac issues as well, and figuring out what's safe to do. And it can be dicey, but some of the simpler interventions often are helpful. And then lastly, for me, talking about painful foot dystonia, this can be either a sign of being low in dopamine. Often it's early morning symptoms because you go through the night without having had your meds. But it can also be caused by dopaminergics. We try Leorisol, we try benzos. We used to use the anticholinergics, and we don't really do that so much anymore. And really, mostly we do Botox injections, which all of you could do to help with this. And it can be pretty effective. For the postural instability and falls, of course, we always want to look at the blood pressure issues, make sure that we're not causing more problems with our meds or side effects from interactions, assess environment, those kind of things. Sometimes, a lot of times, they're because of hesitations and freezing, and people then their center of gravity keeps going, their feet are stuck, and then they keep moving. So adjusting meds and trying strategies to help with freezing, and there are a lot of interesting strategies, can be helpful. I don't do the DBS adjustments, but we may have to send somebody, back to try to see if that's the problem, if they have a stimulator, and of course adaptive equipment. And then we refer to Dr. Ott. So just don't hit that.
Okay.
So that's the pointer forward and back.
Okay, thank you. So moving into what physical therapist's role is in treating these patients, I wanted to start with a case of a 68-year-old male who was recently diagnosed with PD in the last couple of years. And really his most noticeable or most bothersome symptom was right or left hand tremor. And his family had noticed he was kind of slowing down a little bit, but not really a lot of functional impairments yet. And fortunately, he made his way to physical therapy because we have kind of a standing protocol now in our movement disorder center that every patient comes yearly to physical therapy for an evaluation. When we evaluated him, his gait speed was still within age-matched norms. His balance looked very good. So we weren't picking up on a lot of real red flag concerns. However, we did notice a lot of bradykinesia and hypokinesia on the left side that he wasn't really aware of. And so those are things that we did want to address in physical therapy. There's really been quite a paradigm shift in physical therapy and our role with these patients in the last 10 to 15 years, where we used to get referrals for patients in later stages of the disease when they had a lot of disease burden and a lot of limitations. And at that point, our role is really helping them to compensate with those things. So we may not see lots of improvement, but we're going to maybe put equipment or resources in place to help them. And as I was mentioning, now we've seen a big shift to seeing these patients at the time of diagnosis. And that's really critical because we know that there's already been a lot of brain change at that time. The patients are often deconditioned and they have some impairments that they're not aware of. So that's our role, is really to kind of bring those to the forefront. So early on, again, we're identifying impairments that may become more problematic as the disease progresses. And really helping those patients develop interventions that may help to slow the progression of those impairments, or even prevent some deficits. Like, we're really focused on preventing more rigid postural abnormalities. If we're noticing some postural change, that we want to maintain flexibility there. As Dr. Baer mentioned, definitely a big focus is on preventing frozen shoulder, other pain issues like radiculopathies, and things that might be coming from rigidity, especially truncal rigidity. So we're really helping to kind of tease out those impairments and then helping the patients to have the right exercise program to address those. So Most folks are probably pretty low activity level, or they're being active but maybe not to the intensity level that we know that they need. So we have a lot of literature now to support that our biggest emphasis with these patients should really be high intensity cardiovascular exercise. And when we say high intensity, we're looking at 70% or more of their max heart rate, 3 to 4 days a week for 30 minutes. So we're identifying some of these impairments, and then we're also getting them onto a more appropriate exercise program when we can. There's also been some literature on the importance of strength training as well, and especially in fall prevention. So we're typically seeing these people 1 to 2 times a year, and we're just giving them a lot of education and a lot of guidance on how they can incorporate things. And then people are kind of taking that in a lot of different directions. There's a lot of great classes available, like boot camp classes. So we're shifting away from yoga and Tai Chi and kind of going to these high intensity options, but dancing, hiking, whatever they enjoy. So I'm going to show a video of this patient. Just make sure that's muted. Okay. And I'll just kind of talk through this as we look at it. So this is the gentleman who did not notice a lot of impairments himself. And so we're focusing a lot on that hypokinesia on the left side. So we're trying to increase his amplitude of movement. And if you can see, there's some targets on the treadmill, and I'm cueing him to step bigger. And then we're working on backward walking, which is really novel. It's harder for coordination. And then I'm trying to help him be symmetrical side to side. And then you can really notice his left arm in a lot of these exercises where he's not getting the same amplitude. And then you really start to tease out some balance challenges that he's not aware of. So you'll see the right side compared to the left on how well he can reach and using some resistance. So we really are trying to incorporate that strength training and power. And then this is dual tasking. So he's trying to do a complicated step and a different arm movement with a weighted ball, and he really struggles there. And then another kind of more complex task. So this gentleman, when he was diagnosed, he did a great job of really stepping up his exercise on his own, but he was doing things like walking on the treadmill and doing weight training, and he wasn't doing these kind of things that were addressing his left side. So we wanted to add that into his program. Okay. So then moving into someone in later stages of Parkinson's is a gentleman in the same age range as the previous case, 63 years old, was diagnosed 7 years ago. He's struggling with some pretty debilitating freezing and also some more advanced postural abnormalities. So he actually uses a power wheelchair for all of his community mobility and even sometimes in the home. And then he's using, you'll see in the video, a U-step walker that's specialized for freezing of gait. And so he's coming into physical therapy to work on that household mobility and preventing falls in the home. So in later stages, like I was mentioning, we do shift a lot towards compensation. So making sure people have the right equipment, a lot of caregiver education, but still working on some of these deficits that don't respond as well to other medical management, like medication. So such as working on freezing, postural abnormalities, and fall prevention are still really important things that we can provide in physical therapy. So we'll see a video of this guy. This first part is just showing you his gait and the freezing that he's experiencing. And this is my intern working with him. And you'll see his walker. And then also noticing his posture. So he has that camptocormia, that really forward flexed kyphotic posture. And then he's experiencing some freezing as he gets to the turning point. And then we're cueing him and helping him kind of get out of that freezing and keep walking. So the walker, we'll talk about more in a minute, but it's a heavy weighted walker, and it works in reverse where the individual has to squeeze the brakes to make it go. So if they lose attention, it stops. So now we're kind of simulating a situation that brings out his freezing where we're having him go in some tight turns around cones. And again, my intern is kind of having to cue him verbally to help him not freeze. You can see the walker a little closer, and he's squeezing the brakes. Okay, so there's some more freezing. So this, again, just kind of to give you an idea of how he moves on his own. Now we have this walker comes with a laser pointer on the floor. So now he's being cued to step up to that laser. So you'll be able to see kind of the difference from before. And you can kind of see the laser. So we're giving him now more of a visual cue versus before we were giving him an auditory verbal cue. And he's doing a lot better. So a big part of our intervention for freezing is we want to simulate a lot of the situations where the person's experiencing freezing to make it more routine for them and to help with some of the anxiety that comes about when they experience freezing. So now we're working on changing direction, which is another time where he's having a lot of freezing. So he's working on just being able to take one big step to turn instead of multiple little steps. And just turning back and forth. And then he's going to go the other way. So this is something that would be really important for him in the bathroom or maybe getting in and out of bed where he has to make a turn and we're worried about falls. And now we're just trying to quickly change direction. So he has to work on that ability to direction change and then coordinating his arm and leg movement. And then he's still using the walker for some balance, obviously. And then working on sit to stands is something we do all the time with everyone. And then you'll see I'm cueing him about his posture. So he's got really poor awareness of the camptocormia. So I'm trying to get him to really lift up, look up, use his arms to help him. I don't need to go back over there. Okay. So again, going back to the freezing, so some of the gait aids that are available is this U-step walker. They also make laser canes that can be helpful for a visual aid. We use different auditory cues. So sometimes people have a beat, like a metronome, music. We just had an article this month in our PT journal about actually patients had a lot of success singing to themselves internally, not singing out loud, which I had never seen. So different things like that. And then again, we know that anxiety is kind of this vicious cycle with freezing where people start to have a lot of anxiety around, is it going to happen? I feel like I'm about to freeze, and then the anxiety actually makes it worse. So again, we try to put them in a lot of scenarios where they are really challenged, they kind of overcome that. And then also working on different strategies. Okay, so when this happens, you're going to stop, you're going to count to yourself, you're going to breathe, whatever they need to keep going. Fall prevention is pretty obvious, but a lot of that stems around caregiver education because people start to have a lot less awareness of their impairments and poor safety awareness. So we actually are trying to educate caregivers on that this person might need more supervision. Sometimes it is going towards a wheelchair, and like that gentleman is much more functional and safer, and he can do so much more in his day-to-day life with a power wheelchair. So those are different things that we kind of explore with PT. And then finally, the postural abnormalities. So the top row of pictures being the camptocormia, the forward flex posture, and down below being anticollis or Pisa syndrome. And again, these are things that are not responsive to medication or intervention that way. We do a lot of things, first of all, just to try to make sure the person's flexible to move out of that posture. So especially if we're noticing it earlier on, it's really critical that we're maintaining spine flexibility. And then strengthening, especially through the thoracic spine and the neck. We do a lot of things against gravity, so in prone and quadruped. We do work with orthotists on bracing, which can be successful too.
Great. So for the end of our talk, I'd like to give an overview of what palliative care is, how we can integrate it into the care of people with Parkinson's disease, and then really try to bring to life what it's like living with Parkinson's disease. And so palliative care, a lot of people have heard of what it is or think they know what it is, but there's some confusion sometimes about what it really is. It comes from the word palliare, which really just means to cloak. And I like this because the idea is to have an extra layer of support, kind of like a cloak. It's a medical specialty. It's also an approach to care, the care of people who have chronic, serious, or life-limiting illness. And it's about quality of life, trying to diminish or eliminate or deal with suffering from several different angles, focusing on complex symptoms, psychosocial issues, spiritual well-being, and planning for the future. Those are kind of the pillars of what we try to tackle. It's high touch, not high tech. And so palliative care is not hospice. It comes with this stigma Just this afternoon, I was seeing a patient on the inpatient palliative service, and they were so skittish about our visit because they thought we were going to come and talk about end of life and hospice and so on. And while we can talk about that, certainly, palliative care is upstream from hospice. Hospice, as you probably know, is for people that strictly have a prognosis of 6 months or less, as best we can tell, if the disease runs its normal course or its expected course. Hospice is also a funding mechanism. It's usually home-based. It's not a place where you go so much as a team that comes to you or to the patient where they are. And it also relies heavily on teaching the caregivers, the family or whoever else is close to the patient, on how to provide care. Palliative care is this whole person approach, but for anyone with a chronic life-limiting illness, even at the time of diagnosis. And so I like to say it's an interdisciplinary approach. So we have the patient and family at the center, surrounded by a team. And as a team, we're trying to approach the care from multiple domains, disease management, but also the physical, psychological, social, spiritual, practical, and end-of-life worries that they may have. And so I use the word interdisciplinary as opposed to multidisciplinary to suggest that we've got all these components, all these different folks, ideally on a team, taking care of the patient, a nurse, a chaplain, a physician, a social worker. Even the family could be considered, part of the team. And the idea here is that as opposed to multidisciplinary approach where each discipline is there kind of coming up with their own care goals for the patient, the interdisciplinary approach, the idea is to be a bit more integrated and have all of the disciplines working together, kind of building off of each other's expertise to create an integrated care plan. And so I'd like you to hear in the words of a patient, his wife, a Parkinson's patient's wife, what she feels palliative care is. Good, the volume is up.
Would be having a team that's dealing with many and up to all the aspects of Parkinson's, because it's not just a simple disease, and how it affects the spouse. And the team has given me more hope, more confidence, makes me feel real again instead of hopeless in a just one-on-one situation. My understanding of how.
And so how does this differ from usual care? Well, in some ways, typical sort of old school care of somebody with a chronic neurologic disease like Parkinson's is the goal is strictly to preserve function. Whereas with the palliative care approach, we're trying to incorporate the relief of suffering coming in multiple forms, not just physical, right? As opposed to an older approach of maybe thinking about strictly prolonging life, living as long as possible. We're thinking about quality of life, while mindful of ultimate decline and death, certainly open to talking about those things. Whereas traditional care may have focused just on the patient, we're trying to focus on the patient in the context of who's important to them, oftentimes their family. And then usual care may have just focused on the medical symptoms, signs and symptoms, and the psychiatric features. We try to incorporate more than that, the psychosocial, the spiritual issues, the practical issues, transportation, what it's like to carry out activities of daily living from a more practical standpoint. And usual care can include team-based approach, but ideally, palliative care is provided in a team, ideally in real time, where all the team members are present. It doesn't always happen that way, but that's the goal, a consistent team approach. And so really at the foundation of palliative care and this approach is the goals of care conversation. And admittedly, when I was a neurology resident, I thought goals of care conversations pretty much were about establishing code status, I have to say. That's what I thought it meant. But I've thankfully since learned that it's really a unique skill set that's about exploring information about the patient. It's a conversation. It's longitudinal, whereas at one time point a patient with Parkinson's may have specific goals. Down the road, those goals may be completely different. So it's not limited to goals at the end of life, but it's how the patient wants to live. And there's a whole host of different questions we can ask. Again, when I was in neurology, strictly doing neurology care, we have this bag, right, with the tools, and the tools are tuning fork and a hammer and all these things. Now I feel a lot more empowered because my tools actually are questions, powerful questions like, what was life like before Parkinson's disease? Seems like an obvious question, but it can really elicit a lot of good information about what they valued in their life before Parkinson's crept in. What are you most proud of? Can also give us insight into how they identify, what they identify with, maybe their career, and having lost that career, this helps us realize, what they're going through in terms of loss. How do you define quality of life? Very easy for us to make assumptions, right, on what we think quality of life is. But until we ask the patient and spouse or caregiver, we don't know how they define it. What are you currently enjoying and looking forward to? That helps us think, okay, what are those things and how can we get more of that? How can we help them find more things they enjoy or do more of what they enjoy? How do you make sense of your Parkinson's? I like this question because you'd be surprised, right, how people interpret their diagnosis. Some people might think it's genetic. Some people might think my Agent Orange exposure in Vietnam brought this on. Other people might think God is punishing me. I mean, we don't know until we ask. And if it is an existential thought about why they got their Parkinson's, thankfully we usually have a chaplain who can try and address those things more skillfully than I could. What's the hardest part of this? I think this is my favorite question. I think it's pretty powerful to ask. What's the hardest part of this? It can bring forth all sorts of information about the practical side, how they're living with it. We might assume that it's the falls, but in fact, maybe it's the anxiety that causes social isolation and they don't go out because of that. So it really helps us in figuring out what's important to them. What are you most worried about? Flipped on its head, that can lead us to their values. I'm worried about my wife not having a good financial setup, after I die. Well, okay, one of their hopes is that financially they're in solid ground and we might be able to help with that from a social work standpoint and dealing with finances. What are you hoping for? Always a good question in palliative care conversations. And so once we've had that goals of care conversation, at least the eliciting part where we're trying to get at their values, what's important to them, what their hopes are, what their worries are, and how they identify themselves, what goes into who they think they are and what their life story is. Once we've established that, the next step in generating the plan of care is to then link those as much as possible to what's medically possible. So in the case of Parkinson's, we're thinking about perhaps deep brain stimulation surgery. We're thinking about, if they're more advanced in their disease and they're kind of near end of life, are they going to want antibiotics? Are they going to want to have hospitalization? What's their code status? Do they never want to live in a facility? All of the values then we link to next steps. And that's the goal of the goals of care conversation. So it's really a negotiation of goals of care and what's realistically medically possible. So if you think about the longitudinal course of Parkinson's disease, ideally we would get involved at the time of diagnosis just to introduce palliative care and establish goals of care at the onset and also identify a decision maker, a medical durable power of attorney. It's never too early to do that. We should all actually do that. So those are things we could tackle as a palliative care team at the time of diagnosis. A little bit later in the course, we could introduce spiritual support, focus on or help out with some complex symptom management, psychosocial needs, care coordination. Usually we're coming alongside the movement specialist as a team to kind of fill in gaps or help support through the course. A little later in the course of Parkinson's, we might be talking more about prognostication, which is really tough in these neurodegenerative diseases. We might be talking more about aggressive constipation management. We might be talking about legacy work, things they want to have in place for their family for down the road, maybe having some family meetings. And then the medical orders for scope of treatment would be an important thing to discuss, bring up at some point along the trajectory, and maybe introduce what hospice is. Maybe we're having a goals of conversation where they're saying, really getting sick of going in and out of the hospital with these UTIs and whatnot. I think I just want to focus on comfort. And we can say, okay, let's talk about the most form. And the best way to achieve that goal is perhaps having a hospice team come alongside and provide that kind of comfort and support. And then approaching further end of the course, thinking about care transitions, whether or not going to a facility makes sense, management of pain, possible delirium, severe anxiety, these sorts of things become more prevalent. And then ultimately, considering hospice. In the U.S., people are enrolled in hospice, in my opinion, much too late and miss out on months, perhaps, of opportunity to have more support, not just for the patient, but for the family. And so, as I mentioned before, hospice often includes education of the family members on how to deal with certain medications, et cetera. It's a team that comes with a nurse and sometimes aides and volunteers, chaplain, social worker, et cetera. And so hospice can be supremely helpful. And then don't forget, once somebody does die while enrolled in hospice, the family is entitled to bereavement support for 13 months afterwards. And so hospice is good after the death of the patient as well, providing counseling and support groups. And so my case is the gentleman related to the caregiver we saw before. He has about 10 years of advanced Parkinson's disease. He's in his mid-60s, say, and he's undergone bilateral STN, deep brain stimulation surgery. And now he's developing worsening bradykinesia and imbalance. And as you probably know, DBS really doesn't do much or anything when it comes to imbalance. He's got some cognitive trouble with a MoCA of 25 over 30. He's got REM sleep behavior disorder, neurogenic orthostatic hypotension, which Dr. Baer spoke about, illusions, not hallucinations, but sort of on the cusp, where he sees something that is there and misinterprets it as something else, and depression. And so we see him in our clinic, and here he is.
But you cannot do things that you got to be smart enough to know what your limits are. The body is kind of unforgiving. In fact, you owe me some rest.
We know we've been robbed of intimacy, that we don't get to go all these places together anymore. It's a challenge even going out to eat. We don't even do that anymore.
That gives us a little insight into just the practical side of living with Parkinson's, both for him and for his wife. And so how did palliative care or our team-based approach in clinic help him? Well, we started to chip away at some of his problems. So we learned in the goals of care conversation that he was previously a welder. He also worked on pipelines for about 20 to 30 years. He was involved in construction, sort of in a supervisory role. He really enjoyed this, and this really contributed to kind of his sense of identity. He also liked fishing, camping, trips around the Southwest, four-wheeling, being outdoors, things like this. And he said, it never occurred to me that there'd be a time when I wouldn't work. I thought I'd work until I die. I think probably a lot of us feel that way too, but he really identified with his job. Things that give him joy, seeking activities that give him a sense of purpose. So he was toying with the idea of running for the HOA board where he lives, and we really encouraged him to consider doing that, and he ultimately did, and it gave him a lot of meaning, and he could draw on his expertise from his job. And even though it was tiring, it was sort of overshadowed by the gratification he got from being on the HOA. He continues to be involved. And then spending time with his grandkids as much as possible. This is what he lives for. And so thinking through ways he can do more of that. He's worried that his wife won't have appropriate finances if he dies first. He hopes to continue to walk, to maintain cognition, and to focus on quality of life. So other things we did for him, for his freezing of gait and worsening imbalance, he was enrolled in physical therapy. He had a different kind of walker, the nitro walker. And for his depression, we started him on duloxetine. He had a little bit of neuropathic pain too, so we were hoping to kill two birds with one stone. We got him some at-home counseling, which was really helpful because it was kind of a burden to have to leave the house often for appointments, and he really enjoyed this option and realized the importance of socialization and didn't feel quite as isolated. When he did come to clinic, he met with our chaplain occasionally and found that helpful too to discuss coping. And then medications, he was having a bit of trouble taking his multiple carbidopa-levodopa doses throughout the day, so we talked to him about an alarm, and that helped a bit with keeping him compliant with his regimen. And then his caregiver, who you heard from, she was really talking a lot about burnout and the struggles she's having. Their relationship's just nothing like it used to be. So we encouraged her to socialize. She joined Kiwanis. She's in an adult sorority, and she's become very social or kind of revved up that part of her life. We talked about respite care, which not everyone knows about. You know, the opportunity to spend, for the patient to spend a few days, 5 or so days in a facility where the caregiver can step away and travel or just have time to themselves. And then she also met with the chaplain, sometimes separately from her husband, and found that helpful. So that's kind of how we started to chip away at addressing some of their issues. And again, focusing on quality of life, we often think we know what that means, but until we ask the questions, it's very personalized. And one last snippet from him about quality of life.
It ain't bad considering how other folks are, what I'm able to do, and still have new days, have bad days, also have new days, which is being God with bad days.
You know, it'd be easy to assume that life was just awful for him, and certainly there are days or half days where it really is, but we're constantly surprised by the resilience of our patients. And so in summary, palliative care aims to improve quality of life of both patients and their caregivers or families. It's ideally team-based, addressing not just the medical and physical side of things, but also psychological, spiritual aspects, incorporating management of complex symptoms as needed, and it's really this extra layer of support, as I mentioned. And just in one phrase, it's to do as well as possible for as long as possible in the face of serious or life-limiting illness.
Now, that's one of my patients, and really, actually, her worst symptom was anxiety starting out. She has a lot of pain issues, but anxiety was what we had to deal with first. Now we're dealing with a lot of tremor and her pain. So, looking forward, we didn't talk about this yet, but we now know that Parkinson's disease has a very long prodromal, or we call premotor phase, because when is the diagnosis made? It's made when the tremor comes out, or when people start slowing down more than you just expect for aging. That can get missed for a while if it's just slowness. So that's when the diagnosis is made. That's our time zero. But really, symptoms, some non-specific symptoms and some more specific symptoms are creeping up over decades. Constipation's hard to tell, but like REM sleep disorder, REM behavioral sleep disorder, has a very, very high likelihood of resulting in a synucleinopathy, either Parkinson's disease or MSA or something else. And so the work now is on developing ways to detect, the premotor stage of Parkinson's and make that diagnosis early, and particularly looking at those cohorts that have strong genetic predispositions first to try to catch that, with the idea that we are developing, I think it's the wrong direction, that's why. We're developing neuroprotective agents now and strategies that are really exciting. We do know that the literature that we do have at least available right now for what might slow neurological disorders and help to deal with the symptoms is exercise. There's some good, especially the aerobic high-intensity exercise. So we want to get involved in the premotor stage with some high-intensity activities and prehab and neuroprotective agents, and then possibly at the time of diagnosis, we expect that there'll be some progression and diagnosis of motor symptoms, that's when a comprehensive interdisciplinary or multidisciplinary team should be taking over and continuing all the way through the course of the disease. Any questions? No? Okay, yeah.
Yeah, it's a great question. Thanks. So the question was about how to bring up palliative care sooner in a disease course, ideally at the time of diagnosis. And this can be a struggle. On the other hand, if it's part of this sort of streamlined approach, and it's just, this is how we, here we are, we're doing this, and you're going to see palliative care, and, this is part of how we do it, is one way to go about it. So on the adult side, in patients with Parkinson's who are being considered for deep brain stimulation surgery, now all are seeing us. And it's not at the time of diagnosis, sure, but it's perhaps a little earlier than they might otherwise see us. And they don't really know what it is. And sometimes I feel badly about that because they're like, I have no idea why I'm seeing you. And we're like, okay, well, let me explain. And I kind of explain as I just did. And then by the end of the visit, hopefully we've provided some value. If nothing else, they've told their story and we're able to give that to the other team members. So having it sort of incorporated into a program is one way. Some people like to call it supportive care rather than palliative care. I'm a purist, so I try to stick to the word palliative because I like its meaning. But other people feel that if they call it supportive care, I think at MD Anderson, once they changed it to supportive care, I think the number of consults went up exponentially because people weren't as skittish about it. So you could consider calling it supportive care. So I think streamlining it somehow to be like, this is how we do it. You're automatically going to see this team. Either you'll see them one time or you'll see them periodically. So we see patients in one of three ways. One time, like one and done, so to speak. Staggered visits alongside the main neurologists, not more visits, just staggered, or we assume full care for them. So those are just some thoughts off the top of my head.